Ladies and gentlemen, welcome to the third plenary at this year's PMAC 2020. If you could please take your seats, although obviously feel free to stand at the back if you want to do a spot more exercise, that's absolutely fine. So we're going to be looking forward in this session. We've had some absolutely fascinating discussions about the state of play as to where we are on UHC and where we want to get to. But we are going to now be looking at the immediate future, what's coming down the line in UHC, and particularly some of the big sort of thematic areas that might help accelerate progress to UHC, but also that may pose threats to UHC, which will stop our progress. And the way we're going to structure this session is to have two very short presentations to start with, are perhaps two of the most exciting UHC reforms being planned in the world at the moment, in Africa and South Asia. So first of all, we're going to hear from Aquina Thulare, who's the Special Advisor to the Minister of Health in the National Department of Health in South Africa, about South Africa's exciting NHI reforms. Then we're going to hear from Henna Dhawan, who is the Deputy General Manager of the National Health Authority in India, about the enormous Ayushman Bharat health reforms in India. So they're going to give us a picture of what they want to do in the immediate future in UHC. And then we're going to turn to some experts who are going to sort of be telling us about some of the things that are going to perhaps help or hinder them in three thematic areas. Firstly, we're going to be hearing from Parry Aftab, who's the founder and executive director of the Cyber Safety Group, about what might be happening in terms of information technology and the world of cyber, which obviously is going to be crucially important to the future of UHC. Then, of course, recognizing that so many of the things are to do with economics and financing, we'll hear from Correa, who is the executive director of the South Centre, about the big impact that we're going to see in changes in the global economy. And finally, and of course, one of the great threats that we're facing at the moment is climate change, and which we believe is going to be a topic of next year's PMAC. So what might be happening in the world of environment and climate change that will potentially help or hinder progress to UHC, not only in these countries, but across the world. So, without any further ado, and I should introduce myself, of course, I'm Rob Yates. I am head of the Centre for Universal Health at Chatham House in London. But to start off with, if we can hear about South Africa, we're hearing big, exciting things about your NHI reforms. So, Aquina, if you can let us know, in a brief update, what are you planning in South Africa?
Thank you very much, Robert. Let me start by conveying the apologies of Dr. Zweli Mkhize, our Minister of Health, for not being able to be here in person. And our Minister is also expressing support and solidarity to all countries affected and impacted by the coronavirus outbreak. South Africa is in the process of implementing its national health insurance as its strategy of moving the country towards universal health coverage. The journey towards universal health coverage started in earnest in 2009, but South Africa had been grappling with providing universal health coverage to its population since as far back as 1936, when all of us probably were not there. But because of the political dispensation at that time, it was not possible to implement this effectively. However, following the democratic dispensation in 1994, discussion started. Mr. Nelson Mandela, our first president, had come up with policies that made primary health care free and maternal and child health care services free in our facilities, in our primary health care facilities. In 2009, there was a breakthrough conference that decided that South Africa must now move earnestly towards universal health coverage. Having noted that our health system was highly fragmented and it was highly inequitable. 16% of the population enjoyed 50% of the health resources, whilst 84% of the population were served in the public sector and only were covered through expenditure of 50%. South Africa is also described as a upper middle income country, but of interest is that its Gini coefficient is at 0.65, which demonstrates that the majority of the people there are living in poverty. There are high levels of unemployment, with the official unemployment rate being at 28%, but the unofficial one being at around 45%. Government spends about 15% of its total public health expenditure on health, whereas as a total percentage of GDP, South Africa spends close to 8.8% of GDP. It also faces a high burden of diseases, such as the double epidemic of tuberculosis, HIV, as well as non-communicable diseases. But in addition to this, we also have high levels of trauma and violence as a result of effects of alcohol and a violent society. Our levels of cardiovascular diseases, hypertension, diabetes mellitus, obesity, cancers, and mental health are rising. These problems are worsened by a shortage of key human resources, especially in our public health system that looks after 84% of the population. 64% of our medical doctors are in the private sector, and the public sector, which has got the highest burden of disease, is under strain because of this maldistribution. In addition, our infrastructure is dilapidated and is not coping with the high numbers of people who are coming in, and also inadequate maintenance of our facilities. The health system is described as being hospice-centric, meaning that even though we came up with free primary health care, in the private sector, the services are hospital-based, and in the public sector, because of dissatisfaction of the public, they tend to want to go to our hospitals instead of our clinics. So the urban areas are more supplied by resources, including human resources, whereas rural areas are not adequately served. So our strategy to move towards universal health coverage was informed by the SDGs, Goal 3.8, as well as other dispensations that had been adopted through the AU mechanism to ensure that governments take ownership of health financing and not rely on other sources. The areas that I want to highlight in this presentation are around the types of reforms that we are currently undertaking in South Africa in terms of legislation, in terms of strategic purchasing, in terms of how we are managing the public budget especially, in terms of strengthening the primary healthcare approach and improving quality. I also want to touch a little bit on the engagement with civil society. The National Health Insurance policy was adopted in 2017, and the legislation is currently going through Parliament. It was tabled in Parliament in August 2019, and it's currently undergoing participatory democratic consultations in Parliament in line with how our legislations are processed. The political economy of this bill is very, very complex. When the policy and the bill were discussed, it evoked a lot of responses from various stakeholders. And if you map them on your stakeholder map, you will find that we have got winners and losers in the whole debate. Those that are perceiving our reforms as going to benefit them are usually communities, civil society, the workers, and rural communities. However, those that have mounted a very, very hostile response to this policy proposal and the legislation are those that have been benefiting from the currently inequitable health system, such as those that are in the private sector, some think tanks, and some policy entrepreneurs that have been using the media to drive the negative sentiment. Also interestingly is that some medical practitioner doctor groups have come out vociferously opposed to the bill because they say that they don't know how they are going to guarantee their payment, especially those that are functioning in the private sector. What is also fascinating is that as a country we adopted an approach where the President of the Republic, His Excellency Mr. Ramaphosa, has taken leadership of driving this process of legislation and transforming the health system. In his office, he has created a war room that advises him on how he should be providing leadership and guidance. And this war room also is capacitated by international expertise. But what has happened is that with him guiding the process, even where there are tensions between ourselves and the private sector or between ourselves and other government departments, he has brought moderation to the debates, and it has been greatly appreciated. Our NHI is going to be a single payer, a single strategic purchaser that is publicly administered. It is going to be funded through internal domestic resources using fair, progressive, and equitable taxation approaches with a combination of general tax revenue supplemented by other taxes that are going to be identified by government. These taxes are going to be collected through a mandatory prepayment for all those that are defined as eligible. The purpose of this is to spread financial risks of illness across the entire population, whilst also protecting the population from financial hardships and also meeting unmet needs. Through the NHI, it is hoped and envisaged that progressive expansion of coverage of health services will be undertaken through other instruments, including priority setting, and this requires political will and in government as well. We are in the process of establishing an office that is going to be a precursor to the NHI fund, and it will be looking at various permutations, including what we have learned from other countries. From Thailand, for example, we have learned certain lessons that how they manage their primary healthcare services, their districts, their contracting units on primary healthcare. We are also working on how medicines are going to be procured more efficiently to drive down costs of medicines, because it is one of the other areas that have impacted negatively on our ability to make services available. I think I am going to pause here, but let me just say that the journey is very, very complex, especially as it relates to the political economy of the reform. Thank you.
Great. Thank you very much indeed. So we're definitely hearing that politics is going to be potentially a problem, a decelerator that could be inhibiting your progress. Now, what about the situation in India, a population of 1.2 billion people? Obviously, some very significant reforms happening there. I believe you've got one or two slides for us. So can you run us through the Ayushman Bharat reforms, please? Thank you.
First of all, I would like to convey the apologies on behalf of Dr. Indu Bhushan that he could not be here personally to deliver this address owing to the global situation around the coronavirus. And second, thanks to the organizers for giving this opportunity to share the Indian experience around the Ayushman Bharat scheme that has just got launched the last year. I'll be talking about the scheme, some of its key features, and about the progress that has been made, and the learned audience and the experience that is there in the room. We look forward to the suggestions and the advices from the other countries in terms of our implementation and the operations. Health has been a priority sector since the beginning of the independence, and even today, with the last couple of years, our Prime Minister has kept health as a priority sector in his vision and in his commitment. But despite the outcomes indicator growth that has happened in the last decades, resulting in progress in the indicators around life expectancy, infant mortality and maternal mortality rates, eradication of polio from the country, the out-of-pocket expenditure on health still remains very, very high. And as a result, 60 million Indians are falling below poverty line every year on account of catastrophic health expenditure. Ayushman Bharat, the scheme actually means Long Live India in Hindi. It's a sign of a greater political commitment to the health interventions in the country. Sorry. So last year, Indian government has conveyed its extreme political commitment to the scheme, taking a key interest in the health interventions. In a bid to ensure access to affordable healthcare to the large population that is there in the country, Ayushman Bharat was launched in 2018. As you can see here, it has two pillars. So the first pillar reflects the comprehensive primary healthcare delivery through setting up of 150,000 health and wellness centers across the country. The second pillar is extending secondary and tertiary inpatient care through private and public impaneled hospitals through PMJ, that is Pradhan, Mantri-Jan, Arogya, Yojana, that I'll be talking about more in today's session. Combined, Ayushman Bharat reflects the continuum of care approach that India is taking on addressing the challenge of UHC. So the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, PMJ, as we know, was launched on September 23rd, 2018 by the Prime Minister. It aims to cover 540 million people, poor and vulnerable people across 107 million families, which represents about 40% of the country's population. It extends a cover of 500,000 rupees, equivalent to 7,000 US dollars, for secondary and tertiary hospitalization care, which is fully funded by the government. The benefits of the scheme are completely portable across the country. They are entitlement based, and it has no cap on the family size, on age, on gender, and all pre-existing diseases are covered. There are three main stakeholders in the ecosystem of the scheme that I'm talking about. There is the payer. At the central level, there is National Health Authority that I represent. At the state level, there are state health agencies, and there are insurers in some of the states where they have been engaged. At the provider level, we have the public and the private hospitals, which are empaneled by each state. And then there is the beneficiary for whom we are all working. All of these stakeholders are connected by a robust ID platform. And there are other aspects of the scheme which are all connected via ID platform, which was developed in a very short span of time, but has stood the test of time and the numbers that India has posed so far. As you would know that India is a federal democracy and health is a state subject. So the option with the state is to whether to implement or to not to implement. So the flexibility that is offered to the state is a driving factor in their decision to implement the scheme in their particular region or not. So while implementing the scheme, the states are offered the following flexibilities. They can choose the mode of implementation. That is, the state has the right to choose whether they want to implement the scheme in an insurance mode, where they hire an insurance company to implement, or they can do it in a trust mode where they take the ownership and implement in an assurance mode, or they can choose a mix of both, some part in insurance and some in assurance. The states are also given the liberty to expand the scheme if they so want, both vertically and horizontally. So far, 17 states across the country have expanded the scheme, and that's resulting in 650 million people being covered currently under the scheme. So I missed out. Currently, 32 states and UTs out of the 36 states and union territories in the country are implementing the scheme, out of which 19 are implementing in an assurance mode or a trust mode, as we call, where the state takes the entire ownership. 8 are implementing in insurance mode, where they have hired private or public insurance companies to implement, and 5 are implementing in mixed mode. So if you appreciate that India is such a vast and geographically spread country, with all these 36 states and union territories having their own peculiarities and their own approach to how they tackle the health challenges that they face. So we are having an enormous challenge of combining these 36 systems into our one unified national system. So at that level, the National Health Authority has developed a robust IT system and given the option to the state if they want to use the central IT system, or they can, if they have their own IT system, they can integrate their own IT system with ours so that the portability that's a feature of the scheme doesn't get impacted. The scheme also allows state-specific customizations in processes and IT as well. So portability is an important feature of the scheme, where a beneficiary, no matter where he or she belongs from, can take a treatment in any of the empaneled public or private hospital across the country. So far, in the last 1 year and 4 months of implementation, more than 80,000 portable treatments have been done in the country so far under the scheme, worth 2 billion rupees, or about $28 million. The momentum that has been gathered in the last 16 months has been a good beginning. So some of the numbers are here. So out of 36 states and union territories, we are implementing the scheme in 32. There are 4 which are yet to join. We are covering about 133 million families, 120 million e-cards, which are issued to the individuals. More than 21,500 hospitals are empaneled across the country, of which 46% are private. There are 3 e-cards being generated every second, 9 admissions are happening every minute. About 80% of all the claims which are entering the system are paid in time. 8 million treatments worth $1.5 billion US have been done in the last 1 year and 4 months. So the growth has been good, the momentum has been good, but it's just the beginning, and there's a long way to go for the scheme, and there are a lot of challenges to be faced. We are just hoping that PMJ becomes an important enabler in the country for greater health sector reforms. As the scheme has given potential of demand at the lowest level in rural areas, and with the support of the government-funded scheme, it's envisaged that it will incentivize the expansion of services in the underserved areas. More and more hospitals will start operating in Tier 2 and Tier 3 cities and rural areas. As we are providing the package rates, which are predefined and they're competitive with checks and balances in the system, it is expected that it will catalyze efficiency and quality in the currently unregulated private sector in the country. The money that is earned by the public hospital through the treatments that they extend under the scheme, they are allowed to keep it with themselves. So it's expected that the public hospitals will perhaps expand their infrastructure and services, which will add to the revitalization of the public health care structure, and they'll prioritize quality services to the poor. In states and at the central level, a lot of smaller schemes are being converged and merged into Ayushman Bharat PMJ. So the expectation is that we'll reduce the fragmentation of risk pools and costs even further. Along with the other pillar of Ayushman Bharat, the health and wellness centers catering to primary care, the vision of continuum of care, India will march fast ahead on that. And last but not the least, the hope and the wish is that the future for India is irreversibly locked to the universal health coverage through this scheme. I would just like to end the presentation with a quote which epitomizes how we work for the scheme. It goes like this, that, coming together is a beginning, staying together is work in progress, and working together is success.
Fantastic. Thank you very much indeed. Excellent. Thank you, Henna. So there you have it, two hugely ambitious sets of UHC reforms coming down the line, and now we're sort of going to turn to our sort of weather forecasters, as it were, what we might expect. And you heard in the Indian context there, a big emphasis on information technology seen as a facilitator for UHC, but it's a two-edged sword, isn't it, information technology? So who better to talk us through this than Parry? What do you see information technology doing in terms of accelerating or decelerating progress?
Way to turn this on? Is there a button at the bottom? Okay, we'll swap. So much for the technologist on the panel. I'm talking about technology, and each of you will have a different idea in mind about medical technology and the future of technology. And luckily, I have an NGO in India, so I understand the power of technology in India and where they went from a all-cash system to an attempt for demonetization, so that you had to make payments and do banking on your cell phone, even in little villages where you could only charge a cell phone using a bicycle and a generator. So we are finding a collision between reality and technology and universal health care. We have Internet of Things for those of us at our house, where our refrigerators will talk to our diets, and it will set the temperature of our home or measure whether our parents are taking their medication. And we have the Internet of Medical Devices. So all of you who run large providers and health facilities, and even some of your smaller practices, will be relying on technology to manage your data and your patient records that may be looking over x-rays to determine breast cancer lesions. You are looking at things that will monitor breathing and people in recovery rooms. And we rely on it so much without realizing that we shouldn't. When you look at cybersecurity professionals, they are driven by dollars. If you talk to any of them, they'll tell you that putting in place certain risk management will depend upon the dollar loss if you don't. Stock price, reputation a little bit, but not humanity. They don't look at humans as a cost. And every time I speak at a cybersecurity conference, and I'm a cybersecurity and privacy lawyer under all of this, and I'll talk about the human aspects of digital, they look at me in a very confused way. Well, how do you value a human? All of you who are practicing in the medical field and part of the medical ecosystem value humans more than anything else. That's why you do what you do. So when you have a tension between those who are developing and protecting the technology that you are relying on for the lives and wellness of your patients, you have a problem. When we start looking at data, we are going to be seeing the divide between the haves and the have-nots even greater than we've seen before. You can go to the poor and get so much data. You can go to the illiterate and the disenfranchised and those without access and get all of the data you want because they don't know that that data is valuable to them and affects their lives because they are desperate for a few rupees or whatever they may get for sharing that data. And that data is handled however it's handled between there and the time it gets to a hospital in Delhi or New York or London or Cape Town. Integrity of data. As I'm speaking for 2 hours on a panel right after this on AI and universal health care, and AI relies on the integrity of data and large data sets. And where are you going to get large data sets but in Africa and Asia? So as we look at this, we need to recognize that there is a tremendous promise of technology. It will allow medical specialists who aren't in your area to view in through video conferencing and help you through surgery. It will allow robotic surgery if the hospital is set up for that, but the infrastructures aren't there, and infrastructure means money. The training's not there, and training means money. And the more we see that needs to be in place before the digital technology promise can actually be realized will require far more money than any of us are thinking. And the cost isn't that a system's going down. The cost is a fake MRI that a hacker had gotten into and placed what appears to be cancer for ransomware, for fame, because they're bored. Can you rely on the technology when you're making your decisions? Google announced that they were having great results with AI as they were looking at breast cancer, and that they surpassed the effectiveness of oncologists who were reading the x-rays and the MRIs and the scans. And that's wonderful in a very small, practiced environment. So as we look at technology, I can talk about so many of the other issues from cybersecurity and cost and lack of digital literacy. And if you don't have doctors, you're certainly not going to have an IT person sitting there and trying to keep things running. And you may just try to have them keep the Wi-Fi going because they're not going to be able to do the rest. So we need to see it as promise, but it won't be promising unless you're involved. So as the geeks and the coders and the people who live in very dark rooms that you throw junk food to keep them coding are around, they don't understand what you do. They don't understand people. They don't understand medicine. They don't understand healing and wellness. So my challenge to you, and if you want to learn more about the actual tech part, you have to come to the next session. My challenge to you is to be involved. So I run the world's first cyber safety charity. It's 26 years old. I was an early geek. And we're starting a program called Cyber Wellbeing and Cyber Wellness, and that will come from you. You need to recognize the risks that digital can, not just through ransomware, but children who are cyber bullied, women who go to breast cancer support groups online to find them filled with trolls, those who attack others and infiltrate their accounts, those who cyber bully autistic children and sexually prey on deaf and hard of hearing, those who lock children out and all of us out, those who prey on scams with our senior citizens. So the promise of being able to live out our lives at home works if you live in New York. It may not work if you live in the outskirts of a small town in Kerala. So we need to recognize what we're talking about. The technology that you're using that can be very helpful. The technology that's down the road, and you have to be involved in how that's designed, so it's designed ethically and it's designed with thought. It has to be cyber wellness by design. You don't overlay it. It's got to be in the beginning. Otherwise, we're in the days of snake oil, when all of us were selling things that we thought would work and talked you into buying them. There are no standards that are being applied here when it comes to most of this technology. You rely on standards. If there's a medicine that you're prescribing, you rely on the fact that it's gone through tests and somebody in the government somewhere has said, yes, that works at these doses. But there's nothing like that in medical technology, not yet. And if you don't raise your voice, you won't have a voice. And without a voice, you're going to allow all those people who like to code and don't know a lot about people and their needs and humanity to make decisions that really should only be in the hands of medical practitioners.
Fantastic. Thank you. So some really salutary lessons there that if, yes, absolutely, that if we want information technology to work for UHC, we really, really must get involved. And some worrying signs there that, you know, if we don't, that it could also exacerbate inequalities, which is, of course, definitely what we don't want. And I'm sure this is going to be an issue that, Carla, so you're going to have sort of concerns about thinking about what might be coming down the line in the world of the global economy. How's that going to affect us in the UHC world?
Well, thank you very much, Robert, for the invitation to the South Center to participate at this panel. The South Center is an intergovernmental organization of developing countries located in Geneva. So let me start by noting one of the estimates of the WHO report about universal health care, which indicates that in order to get universal health care by 2030, there will be a need of an investment of $200 billion per year in low and middle income countries. So the key question is, where is this money coming from? Would it be possible to get this money in order to achieve this objective? Otherwise, in accordance to this report, about 5 billion people will not be able to get access to health care. So in order to get these resources, there are two sources, one domestic and the other one foreign sources. So let me first address domestic resources. The prospects for the economy, for the world economy for this year, are not so bad. Economists are thinking about a growth of about 3%, with a lot of uncertainty, really. But the bad news is that for most developing countries, in accordance to the IMF, about 80% of developing countries are now with a world economy, growth economy, which is going down and not up. A clear example is the case of China, which has impacted other developing countries, but the reality is that the prospects of economic growth in developing countries are not as promising as for the world economy as a whole. So this means that the resources, the domestic resources needed in order to make the investment may not be there. Secondly, many developing countries are finding difficulties in order to mobilize local resources through taxation. Illicit fund transfer, for instance, is a major problem in many African countries. Taxation in the digital economy is another challenge. Many companies, in particular big digital companies, are doing profits in developing countries, but they are not paying taxes in those countries. So the question is, how are these countries going to get their resources? In addition to this, in many agreements that developed countries are signing with developing countries, the so-called free trade agreements or similar agreements, very stringent provisions are being implemented, are being imposed in relation to intellectual property, for instance, which increase the price of medicines in a huge manner. And this is a point that was made by our South African colleague. The fact that medicines should be available is very much linked to the framework, in particular, the extent to which intellectual property are granted or not. So going now to the foreign sources for financing this objective of getting universal health coverage by 2030. So one first observation is that debt in developing countries now has increased dramatically. Today, the level of public debt in developing countries has reached record levels. It's about $55 trillion. 32 developing countries have unsustainable levels of public debt. So this means that these countries will not be able to borrow more money, and in some cases they will not be even able to pay the debts they have with different creditors, public creditors or private creditors. So this source for financing will not be possible there. Secondly, about official development assistance, so-called ODA. ODA is very important, in particular for least developed countries. About 2/3 of foreign aid is based on this official development assistance in those countries. But the situation is that this official assistance has stagnated. It's currently about $150 billion, but it's not growing. And it's a matter of concern, in fact, that the official development assistance to least developed countries and African countries has, in fact, decreased and not increased in the last year. So, again, the question is, to what extent it might be possible to finance the universal health care system if this situation today, this official development assistance is very much focused on humanitarian crisis, in particular the issues relating to refugees and not so much on health issues that are our interest here. And then finally, if we look at private funding, it is very unlikely to fill the gap that the other sources of foreign investment, foreign financing may leave. So I don't want to leave a grim picture, but if we really want to seriously talk about getting universal health care by 2030, there is a need of really bold actions, very bold actions in order to ensure that financing is available. Otherwise, this should be an utopia. This should not be a reality. Thank you very much.
Great. Thank you. Thank you very much indeed, Carlos. So round of applause for Carlos as well there. And some worrying signs again there, and I think, hiding behind sort of general global growth, that there being issues again about inequalities and, sort of, the dangers of things getting better for the better off, but not necessarily for everyone, and obviously that not being universal. So very sobering. Montira, are you going to be able to cheer us up in terms of the prospects on climate change for universal health coverage? Oh, you're missing your microphone.
I'll do my best, but I will smile as big as I can. I'm Montira Pongsiri. I'm going to be talking very briefly about global environmental change and its relevance to UHC. And I was very happy to hear that this may be a recurring theme for next year's conference. So global environmental changes like climate change, forest loss, ocean acidification, loss of biodiversity, these have the potential to disrupt the progress of humanity because of their adverse impacts on key ecosystem services. Ecosystem services are the benefits, both direct and indirect, that we derive from healthy natural systems like our oceans, like our forests. And these benefits include the provision of our food, fuel, our fiber, the filtration of our water, the regulation of our air. Global environmental changes also have the potential to exacerbate already existing socially mediated risks such as displacement. The key messages from the Rockefeller Foundation Lancet Commission report on planetary health from 2015 were that while we've made significant measurable gains in health and development over the last 50 years, they are likely to be reversed by the global environmental changes we are experiencing now. Importantly, the health risks and the widening health and social inequities related to poor living environments can be reduced but also prevented if the drivers and consequences of the changes in the condition of natural systems, like our oceans, forests, air, are understood, and these drivers and consequences are incorporated into our policy and planning. So this presents the opportunity for us not only to reduce risk to health, but also to prevent risk to health by looking upstream and targeting those environmental drivers of health. So that's a bright spot. That's the opportunity that we can work on together in innovative, multi-sectoral ways. What are the implications for UHC? I don't think we can achieve UHC without addressing global environmental changes like climate change. And I'll focus on climate change here for 3 reasons. 1, climate change can affect population health, both in direct and indirect ways. Climate change leads to extremes in temperature, as you know, leading to higher temperatures, which can affect or cause heat stress and other temperature-related illness and death. Climate change can also increase the risk of vector-borne diseases like malaria and dengue because it creates conditions favorable to animal vectors. Climate change, as we've all observed, can be associated with extreme weather events like flooding, which poses physical threats to people. A second reason why UHC should address climate change is because healthcare services are impacted adversely. For example, extreme weather events can make healthcare infrastructure vulnerable. The delivery of healthcare services can also be vulnerable to these climate change associated events by disrupting the transport, energy, and communications networks. The third reason UHC should pay attention to climate change is that health facilities themselves contribute to climate change through energy consumption, in powering equipment, providing heat, in cooling, lighting. The regions of the world which are most vulnerable to climate change are also those areas which have the lowest UHC coverage. Paying more attention to the climate change drivers of human health outcomes, which we are already experiencing and which are expected to get worse over time, is what we have to do. These climate change health relationships should be included as part of the minimum essential health services coverage and thereby embedded by strengthening the capacity of institutions, of training healthcare workers, and financing. Operationalizing this will require multi-sectoral, both health and non-health sector coordination and actions, which could include activities to mitigate and adapt to climate change, which could help reduce risks to health. Thank you.
Thank you very much. I think you make a very important point as well about our role as the health sector. I think with the health sector making up over 10% of the world's GDP, as it were, at the moment, you know, that we obviously have a huge role in being able to sort of, you know, tackle this issue. What I'd like now is really to throw this open to the audience and have people sort of queuing up to really address the points that the panelists have made and maybe discuss about the UHC reforms we've been hearing. But also, this is your opportunity to say, what other opportunities and threats might there be coming down the line here? Are there other huge thematic areas that we neglect at our peril when it comes to achieving UHC? And if countries like South Africa and India are going to achieve UHC, and if we're going to sustain it, what might we be needing to worry about coming down the line? So if you'd like to sort of queue up behind the microphones, if you'd like to make a point on any of those things, that would be really excellent. But as people are beginning that process, if I could maybe sort of turn to our presenters and say, how much do you think you're taking these factors into account when planning your UHC reforms? Are these areas that you're looking at, would you say, in the future? Or do you think that we're so wrapped up in the health systems reforms we're not thinking about the bigger picture? Not sure if either you'd like to start with that. Aquina, if you kick off.
I think we are not oblivious to some of the issues that have been raised, specifically on the issue of cybersecurity and also the security of our data, because there is concern that, you know, someone may suddenly infiltrate the system and make available information that is supposed to be confidential. So we are quite sensitive to that, and we are also sensitive to the fact that that information may be used for other purposes that are not desirable. So I agree with you, and I agree also with the issue of environmental impact on our universal health coverage, because if we do not address some of those areas that have been identified, they have got a direct bearing, for example, in terms of increasing the burden of disease that we may find ourselves entangled with, and that, you know, if we don't look at the issue of climate, we may find that, you know, the climate catches up with us in future. So we are quite sensitive to those issues. Thanks.
Henna, what do you think about the Indian context?
So I echo what Aquina has just said. In fact, in India, perhaps PMJ is one of the first schemes which from the very beginning has tried to look at the international standards with respect to cybersecurity. And we have about more than 100 odd checks which our data goes through for privacy and confidentiality related secrecy and terms like that. And with respect to the environment and the climate change issues, of course, we cannot be in hiding, cognizant of the aspects that are there. We are aware, and it's just the beginning. I'm sure we will keep these inputs in our mind while we expand and we progress further.
And of course, everyone's vulnerable to this, not least our NHS, which was hit very badly in a cyber attack just a couple of years ago. Parry, do you want to come back on that?
Thanks. Well, I have a new sister in South Africa, and I've always been a fan of South Africa, the most incredible people and music and food and wine. And so I've received so many, and you should applaud. I receive so many requests all the time to do a cyber safety program in South Africa. And there was research that was done by one of the schools that I work with. So young people are experts in our programs. We actually have a program that starts at the age of 6. We call them cyber safety agents, and they solve problems and the rest. But we had groups that had done research on a school that had a school in London, one in New York, and one in South Africa. And they were looking at cyberbullying. And in South Africa, the students at the same school, same values, responded saying that they would never use race as a basis for cyberbullying, whereas the school in London and New York were. And that has always intrigued me, and I've wanted to do more. So we started our discussion over tea yesterday, so I hope to be there. There's also a program, we have it, and we can help set it up wherever you want. This is all free. It's called the Cyber Safety Corps, Cybersecurity Corps. And we get cybersecurity students and cybersecurity experts from all over the world, the kind of people you'd never be able to afford. And they, on weekends and holidays and after hours, donate their time for schools, hospitals, NGOs, vulnerable groups that will go out and help do this. And I know in India, Art of Living is doing a lot of that, but we can do that, and I'll bring them in from all over the world. They can do it virtually and work with them young. And if we can get some students started in cybersecurity at the age of 8, you're going to have the best teams in the world by the time they're 20.
So if I can turn to the audience now, and maybe over here first, and then we'll move over there. So what point would you like to ask of the panel?
Yes, thanks. This is Ravi Ram from the People's Health Movement. The UHC in India and South Africa is structured to pay medical expenses, and therefore is not really structured to respond to the kind of planetary or climate changes that we've just discussed. So there are many other ways of providing health reforms. I think health and all policies would be one, looking at the social determinants, and I'm sure you've considered those. But what do your governments have in hand right now to respond beyond how UHC is being structured? And secondly, knowing that it won't be enough, what do you see is required for your governments to be able to respond in the next 5 years to these upcoming challenges?
So if you just hold the thoughts on that one, and we'll take the question from here over there. Thank you.
Thanks, Stephen Harsano from IQVIA. Thanks to the panel for the comments. I wonder if it's possible to connect the discussion that we've been having on this panel on the benefits and risks of technology related to UHC with the discussion on health financing for UHC. So on the one hand, I think we're very concerned about the digital, of sort of privacy and patient privacy in the digital era. But on the other hand, interoperable data systems could also generate insights which help us improve clinical decision-making, efficiencies in service delivery that could otherwise be realized if we crack the sort of data code there, right? But I guess the question is, how would we balance those priorities and really make concrete progress so that we can use technology to help with the overall health economics for UHC? Thanks.
Thank you very much. So maybe I'll sort of turn to our country specialists. Oh, sorry, is there? Oh, I beg your pardon. Yes, one more in the middle there. Thanks.
Hello. Hi, I'm Renzo Ginto from the Philippines. Thank you for the panel, especially to Montira for raising the issue of climate change in a UHC forum, which you don't hear often. And in fact, in this day and age, we need healthcare to be both climate resilient, but also to decarbonize. And this is a good segue for our next session later on climate and UHC. So this is an invitation. But this is my other question, and in terms of other mega trends, I think one mega trend that we're not talking about yet is migration and population mobility. And we know that they say 1 out of 7 people are on the move. And in an era of climate change, we expect more and more climate-induced migration to happen. But now what we're seeing, on the other hand, is countries closing their borders, even building walls. And the appetite for migrant-inclusive health systems will probably even decline as a new coronavirus circulates around the globe. So how can we make sure that migrants, people on the move, are not forgotten, not left behind in the era of UHC, in the age of the coronavirus and climate change? Thanks.
And if I maybe just take this last one, then I'm afraid that we're going to, looking at the clock, that will be it, I'm afraid. So just take this last one, please.
Okay. So thank you. I'm Dr. Mohiuddin Usmani from Bangladesh. So my question is to the Indian, very big one, that is Ayushman Bharat, which shows it will incorporate 540 million people, that means 40% of the total population. And all of these emphasis they are giving to the secondary and tertiary care mostly. And my question whether how the public and preventive health will get some priority, or whether it will, the energy and resource will be driven from this part to the secondary and tertiary care, where the hospitals, either public or private, they will get the money from the government for treating the patient, one. Another one, this is the health is a state affair, as I do understand from the Indian part, that, but this is a federal or central activity. Then how the local authority, that means state government, will activate or participate in this as the owner of the health service provider, and how the public hospital, as we know, the Indian public hospitals are not going well, and how the public hospital will improve in comparison or with the competition from the private hospitals. Thank you.
Great, thank you. So I maybe turn to our country specialist first to ask the questions that have been directed at you there. So maybe, Henna.
I'll do a last in, first out. I'll do the LIFO, and I'll take the question from the Bangladesh gentleman first. So on the point of, are we leaving primary and preventive care out? We are not leaving primary and preventive care out. As I started my presentation, there are 2 pillars to the program. I spoke only about one because I represent the organization which deals with that pillar. There is another aspect to Ayushman Bharat, which deals with setting up of 150,000 health and wellness centers, catering for comprehensive primary care service delivery. So that is the program which will take care of the primary care needs. And the second question that was asked was around how is this program going to support the public health infrastructure? So as I mentioned towards the end of the address, that the money that a public hospital earns through this scheme, they can retain that money. They don't need to give it back to the government, or these are untied funds available to the hospital to use it as they seem fit. So they are investing that money in infrastructure upgradation, in engaging services, in engaging consultants and specialists if they don't have right now. Some of the smaller primary healthcare centers are also impaneled in some of the states in the country. So whatever money they are getting, they're expanding the services, and they are giving it out not just for PMJ, but to public at large for other services as well. So that's the response. And to take another question which was asked from here, I understand, that how do we balance the data security, privacy, vis-a-vis the benefits that the data has to offer. Interestingly, the same discussion was happening in another parallel session just before this one, wherein it was being discussed as to how to seize the digital opportunities and also keep a balance with the risks that it has. And we are very cognizant of that fact, though in the last 1 year, 4 months, it's not a great period of time to do very sophisticated AI and machine learning, but our systems have been learning, and we are doing predictive analysis on how to control certain outbreaks if we are getting hints at that. And on the other aspect, we are being extremely cautious of how we share the data, how we put the data out for better analysis perhaps. But we are doing it, we are giving it out to researchers and analysts so that we can be better prepared for what is to come in the future. So the balanced approach is being taken right now.
Thank you. And Aquina, and if I can ask you as well to address the issue about migration, because this is a big issue in Southern Africa, particularly people sort of working in your mining sector. So how are you dealing with the migration issue in the NHI reforms?
So the type of issues of migration that we are facing are internal migration, where people are moving from rural areas to urban areas or from cities to cities. But we also have inward migration from neighboring countries. And that is posing a huge strain on the health system because our constitution currently does not allow anyone to be denied emergency care. So when people arrive in the country and they have got emergencies, they have to be seen in our facilities. The question that has been raised and the debate that is raging is around those that are not emergencies. So if someone arrives and they have got a minor ailment and then it progresses and complicates and eventually requires emergency care, how are we going to be dealing with that? And it's part of the debates around the consultation process because one school of thought would say that we do not have infinite resources, and another school of thought will say the Constitution states that you cannot deny, and another school will say that people are already receiving care, so if you regress, it means you are applying a regressive principle. So those areas are areas of contestation, and there have been several proposals on how our budgets could be augmented to ensure that the migrant population is not excluded, including looking at the multilateral mechanism to ensure that they support countries that are receiving migrants, especially those that are coming from outside the country. The unique thing with South Africa is that we do not have refugees that are kept in camps. So they are integrated into communities and they use the same facilities that South African citizens are using. And this has created a lot of unhappiness, but government is listening to all the views that are coming up so that we can come up with a comprehensive approach. One last question. On the issue of social determinants and other determinants of health, as South Africa, we have come up with certain dispensations that start addressing the behavior that you may think may impact on the demand for services. For example, sugar, alcohol, carbon taxes. So we are imposing those taxes, and even though when the money is collected, it's not earmarked for tax, but it goes back into the fiscus, and then we are working with Treasury, and it allocates a certain amount back into some of those services.
Terrific. Thank you very much indeed. And maybe our experts as well. Yes, please. And maybe if you've got one take-home message for us, for the group in terms of your thematic area, if there's one thing you'd like the audience to hear from you before we finish. Thank you.
Okay, this is an advertisement. So I run an NGO that's the oldest cyber safety organization in the world. I'm old, and I'm going to have to be stepping down at some point and spend more time with my grandchildren. I am happy to share what we know and do with any of your countries and any of your individuals. And it is a values-based program. We give you basics. You decide what your values are for your community, your culture, your religion, your standards. And so I've been doing this longer than anybody else. I'm happy to share all my recipes. And I will do it with you, and I'm happy to help in any way I can. So we are there, and I'll train your kids to how to help you develop the cybersecurity you need for your medical practices.
Plenty of customers there.
Just one word about South-South cooperation. The experiences of South Africa and India may be very useful for other countries. All countries may be both suppliers and recipients in South-South cooperation. I've heard, for instance, that the case of Thailand has been extremely useful for South Africa. The digital health developments in India may be of great importance for other countries. So what I would suggest is that we need to have a special session about how reaching this major objective about the universal health care system can be promoted through South-South cooperation.
Thank you. I was very happy to hear about the flexibility in the means of implementation of your new program. And I want to reinforce that flexibility in the means of implementation, particularly under the SDGs framework, because that gives us space to address together environmental sustainability and health, and using different non-traditional approaches to improving and sustaining health, including, for example, through environmentally based strategies. So that flexibility, I think, is really important, and we should be asking under the SDGs if we are making progress on economics and social progress at the expense of compromising the functioning of our natural systems, which can undermine human health. So thinking more about the systems and how we might be offsetting and trading off the objectives that we are trying to achieve, I think is important for us to think about in our design and implementation of policies and plans. Thank you.
Great. Thank you very much indeed. And I'm glad you mentioned the SDGs there, because for me, this whole session, I think, really is the complete justification of the whole idea of the SDGs. You know, it's very, very important for us in the health world to get involved in the other SDGs and vice versa as well. So I think for me, that's the key message going forward. If we're serious about UHC, we need to get out of SDG 3 into the other 16, don't we? So thank you very much indeed. That's a wonderful panel. A round of applause for my super panel, please. And they'll be starring in the parallel sessions that will continue after this session. I don't want to plug one above the other, otherwise I'll get into huge trouble. But you'll see that they're each performing this afternoon, and very much encourage you to go along to the parallel sessions, and I hope you enjoyed the session. And please fill in the evaluation forms before you leave. Thank you very much indeed. Bye.